Our last speaker would be Dr. Anil Elhence from India, who will speak on the topic TURP in large median lobe and more than 100-gram gland. Over to you, Dr. Anil Elhence.
Good morning, and thank you for having me here. It's been a pleasure being on this beautiful island. I speak on a resection of a large median gland. Before we do any surgery, we need to understand the anatomy. And rather than jumping into the surgery, the anatomy has to be learned in a three-dimensional aspect, because not just in the two-dimensional aspect we see on a routine per abdominal ultrasound. And why is it important to understand a 3D anatomy? Because it varies. We have all shapes and sizes of prostates, whether it's limited to the median lobe or the lateral lobe. So we need to understand where the tissue lies so that when we do a surgery, we know where we are headed to. So the median lobe could be just simply a median lobe without significant lateral lobes, or there could be significant lateral lobes also. So the size does vary. And why is a median lobe important? It's important because there is an inability to see behind the lobe. We are unable to enter the bladder at times. In trying to resect, we might injure the trigone, the ureteric orifice, and the posterior wall of the bladder. Bleeders at the edge of the median lobe would tend to bleed towards the bladder, may not be seen, and keep the vision down. When the vision is bad, there are chances of further injury. So when we have decided to operate a patient with a median lobe, we need to do some pre-operative assessment, know the size of the median lobe, the site, whether it's arising from the posterior lobe or the lateral lobes or the anterior lobe, whether the base is broad or narrow, how much is the degree of protrusion, and thus the distance from the ureteric orifice. To achieve this, we need to understand that the median lobes could grow just vertically. There could be an anteroposterior aspect also, or the median lobe would grow extensively within the bladder. Similarly, on a horizontal aspect, it could just be a median lobe with or without growth of the lateral lobes, and of course a much bigger enlargement where both the anteroposterior as well as the horizontal development is there. The assessment traditionally has been done by an ultrasound, both abdominal or a truss-guided ultrasound, and we get a fairly good idea in 2 dimensions of the size of the prostate. But is that enough when we are dealing with a very large prostate? So if we do a MRI especially, or a high-resolution CT scan, we would be able to see the exact location from where the median lobe is arising, whether it's from the lateral lobes, whether it's the anterior lobe, so when we are operating the patient, we have a fair idea which lobe is the one responsible for the protrusion within the bladder, and that could be dealt with in a much more efficient way. So in these images, you could see on the extreme left that there is a significant contribution of both the anterior and the posterior lobes, while on the image on the right, it is basically the anterior lobe which is contributing to the medial protrusion. So it's important to understand where we stand. So these are images with the catheter in situ and where we can assess. So when we assess this patient and we are taking him up for a surgery, we need to ensure that the urine is sterile, because obviously infected prostate would tend to ooze or bleed more. We could, in the waiting time while between the OP and the surgery, we could use alpha reductase inhibitors and anti-androgens to keep the blood flow reduced to the prostate, and of course consent for a staged procedure. The intraoperative essentials would be a good endoscopic vision, good flow of irrigant, use a continuous flow, which is now almost routine, low pressure suction at outflow if required, hypertensive anesthesia, and of course control bleeders early. The intraoperative technique would be to create a groove on either side, and this I'm talking about traditional classical median lobe arising from the posterior lobe. Create a groove on either side and control the bleeders which are supplying from the lateral aspect. That makes the median lobe more or less, not truly avascular, but less vascular. Once those 2 grooves are done, we could resect the crown of the median lobe, make it flat till the level of the bladder neck. And this improves the vision. We can now inspect the bladder much well, and the flow dynamics improve, improving the vision. Subsequently, we resect the posterior lobe, and this will cause the tissue at the median lobe to fall backwards, and we could safely resect whatever residual tissue is there at the median lobe. So on a coronal plane, this is when we start, we keep the resectoscope at the level of the veru, flatten out the median projection down to the level of the bladder neck. Once that is done, move the resectoscope to the bladder neck, tilt the scope downwards and resect the median lobe, which is intravesical. Once most of it is taken out, don't take out the entire lobe because then we might be injuring the prostate. We come back, hollow out the posterior lobe. Once that is done, the bladder neck falls back, and as it falls back, the tissue within the bladder rises up, and which can easily be detached. So in these 6 images is a very simplified way of how to do it. Because of time constraints, I'm keeping the video out of this. And when the lobe is arising from either the lateral or medial lobe, again similar, groove on either side, resect the crown of the projection. Once it is flattened out, then we have those bow-shaped curves right from the bladder neck to the distal limit. Do it in stepwise, do not do randomly, and at the end shave off any remaining tissue at the bladder neck. Thank you very much, and I will be happy to answer any questions.